hemoglobin A, or your normal hemoglobin. 4 chains. What are the 4 chains? What are you? 2 what? 2 alpha, 2 beta. Correct. How many mutations then are seen when you have alpha thalassemia, hemoglobin H? 3. Yep. 4 is you're not compatible with both. What is often the first place that a child presents with sickle cell? No? It affects early, is the spleen. Yep, what is that? Fingers, toes, what is that called? Digits, yes, those are called digits. What is it called when they're super puffy, swollen, painful, vaso-occlusive crisis? Dactylitis. Dactylitis. What do you prophylax these children with for sickle cell disease? So hydroxyurea is to help shunt it to fetal hemoglobin, but it's not a prophylaxis. We're going to prophylax. Penicillin, correct. What makes more fetal hemoglobin? What kind of rash is seen in HSP? Palpable purpura. We'll never get that. What organ are you most worried about with HSP for long-term effects? Kidneys, yes. How many days of fever do you need for Kawasaki disease? 5. 5 or more consecutive days. Okay, so let's finish up Peds Heme. Mornings. Okay, so we were talking about all the different things that could go wrong with a red blood cell. So the red blood cell could be something wrong on the outside, something wrong on the inside, something where it sickles, all the different things, intrinsic, extrinsic. Some of these are then those enzymes. So inside the red blood cell, something is missing. And so for G6PD, it's one of the ones we check for in the military. So something to be aware of for kiddos. As a reminder, way back from freshman semester, why do we need G6PD? Well, we have the lovely molecule glutathione. And glutathione sits here with a little hydroxyl group on the end. This little OH group is then going to attach to all of your free radicals and pull the free radicals away so that they don't go in and bust open the cell. So you need something to keep your glutathione in a reduced state so that it can grab those free radicals. If you don't have that, if you are missing the enzyme that can keep that hydroxyl group present, you thus have these free radicals that go in, they attack the cell, causes the hemoglobin to precipitate out of the red blood cell, and that marks it for destruction anyway. So you have bad news if you don't have this G6PD. Why does that matter as much? Well, kids have a much lower threshold to be able to handle these oxidizing agents. So whereas maybe an adult can handle a little bit of this, a child functionally can't. So how do we mark this patient's chart, this kiddo's chart, to say, please don't give them any sulfa drugs, any nitrofurantoin, macrobid, any aspirin? How do we say, don't give that to this kid? It's a terrible system in the EHR. How do we do it? Yeah, we mark it as an allergy. Is that really an allergy? Are we having an IgE allergic response to this? Absolutely not. But it's the only way in the system that marks to say, please, pharmacy, please, other physicians, please, other PAs, don't give an oxidizing agent. Okay? The other one that the tests love is favabeans. I don't know that I've ever eaten a favabine. I think I never will after hearing about it for G6PD. Things to think about. And children, if they're eating mothballs. Don't eat mothballs. Public service announcement. What they will do, those Heinz bodies are the precipitated hemoglobin that is inside the cell. So that marks it for destruction. So Heinz bodies themselves are not super specific for G6PD, but you do see that because these cells do get marked. So if you're looking at lab values or they give you something on the pants, certainly in a deficiency of G6PD, you will see a decrease in G6PD and a decrease in the reducing agent that is available. Your treatment is to not give it. So your treatment is all in prevention, or if something is given, to get them back into that physiologic state where they do not have these oxidizing compounds. Just another look at what that looks like, a Heinz body, where you have the precipitated hemoglobin on the outside, or on the inside, marking it for destruction, and then that is what a bite cell is when it has had a bite taken out of it where that precipitation is. Just a reminder if you need to see that. Okay, so diseases of hemostasis. So now we have talked about what happens with those red blood cells when you have all the things going wrong with them. Now we shift a little bit to talk about what happens when none of this is going right and we cannot clot, or we clot too much. So a quick review from Heme, reminder what thrombocytopenia is, anything under 150,000 or 150, which you'll see pop up on the labs. But really, for kids, really anybody, there's this large area of we're not going to bleed, but we're still too low. So functionally, as a provider, when you're seeing a patient who's below 20,000, 20,000 is functionally where you're thinking, this patient is going to be bleeding from somewhere, from their gums, from mucosa, having nosebleeds, just very, like bleeding super easily. So 20,000 is kind of that mark. 80,000 is your upper limit where you're saying, I think they're going to be okay, and as long as we don't have a major insult where we have active surgery, a car accident, something that is actively going on, they're probably going to be fine. What's happening between 20 and 80, or 80 and 150, is a little bit of the provider brain is, don't know what's going to happen. So depending on what is happening with this particular patient will depend on how much bleeding you see. So really, 150 marks your definition, but your bleeding risk really changes at 80 and then 20. So just the risk factors for that. Remember, when you have platelets that are unable to make that initial clot, you first will have petechia, the teeny tiny little bleeds that extravasate into those capillary beds. When those coalesce into petechia or into purpura, you end up with a non-blanching, quote-unquote, rash that is not truly a rash, you end up bleeding into the subcutaneous tissue. When it is deeper, again, an ecchymosis, call that forever, and then even deeper, a hematoma. A few reminder, kids can clot in places they shouldn't as well. It is much more rare, but it can happen. So if a child has a clot on the arterial side, you are going to have a cold and painful leg because there's blood that cannot get to the periphery, versus if you have a clot on the return or the venous side where you have significant swelling and warm and red because it cannot return back to the heart. So just clinical reminder of those two can still happen in children. Throughout their entire time together in pediatrics, which this is so sad, you only have 4 times left. You're crying inside deeply. But I have said, trust your exam, trust yourself. This is a clinical diagnosis. You really need your history and your physical exam to guide you. This is different. Heme and onc, but particularly heme right now, you have to have your labs. So labs are going to be obviously very critical for this. So yes, you're checking your H&H, but for this you need to know first what your platelet count is. Then you need to know, can I clot anything else? So do you remember from clotting factors which one PT looks at? Yep. 3 and particularly 7. What about PTT? 12, 11, 9, and 8. Perfect. Then after that, you start looking at your platelets. So your bleeding time is more literally, they would have a lab where it would bleed, and they would just watch how long it took to quit bleeding, and an interesting history. Now we look more at the function of that, so the things that you're looking at. So the first thing up for what's happening with something gone awry, it's all just introduction, is ITP. So when I went through 10 years ago, 12, 15 years ago, I've lost track of time, it was idiopathic thrombocytopenic purpura. That was just what the name was. We were like, we have no idea what this could possibly be caused by. They're in the middle of changing the name to immune thrombocytopenia, thrombocytopenic purpura, because they're seeing, oh, this is actually to do with the immune system. So likely, by time you guys are out in practice and we are having this discussion a few years from now, we will all only be immune thrombocytopenia purpura. ITP, the name is not going to change. Super common in children. We've talked a couple of times about instances where the body will make an antibody and it will get very confused. And it likes to attack different parts. So think about rheumatic fever. We have had a strep antibody that is then going to go after the heart. Or we have had maternal lupus that is going after the pediatric heart to cause that heart block. So there's certain times that we've already talked about where these antibodies will go attack unprovoked. So this is one of those times. Some sort of virus creates an antibody, an IgM, that will then convert into an IgG for more long-term, persistent, that marks the platelets and attaches to the platelet membranes and will then destroy your circulating platelets. Or at least mark them so that the spleen will go do this. So this typically happens after this kid has a viral infection. So they have a typical run-of-the-mill common cold, URI, no one's thought anything about it. A couple weeks later, now all of a sudden you start to see some of that bleeding, bruising, TKI, mucosal bleeds with brushing teeth, things like that. Or even more significant ones. So, but it is likely from, nobody's been able to pin it down yet, but likely from some specific IgM that is converted after a viral infection. So the nice thing about this when you look at labs is everything else is absolutely normal except for your platelets. Everything else, WBCs, RBCs, everything else is normal. When you look at your erythroid, myeloid lines, your red blood cell lines, your white blood cell lines, everything else looks normal. You just have a whole bunch of megakaryocytes. So they're just being pushed out of the bone marrow early to try to be these baby platelets. You see, so everything else is normal except for your platelet count. So we already talked about that then, is when do we actually do something about this? So really when we talk, say that 20,000 is where you see this bleeding risk. So we've gone above and below that. So if you're above that kind of 30,000 mark, you're probably doing okay. We'll probably just watch you. So this is something to think about if you are in a family practice or in a group that is seeing, especially older kids. So thinking about, is this kid playing sports? Is this kid going to be doing jiu-jitsu or football or soccer, something where they're going to have a lot of contact and they have this bleeding risk? I might not be treating them at 30,000, but I do need to make sure that they are not putting themselves at significant risk to bleed. So that would be thing one. If you're down then below that 20,000 mark, and certainly below 10, now you're at risk true for active bleeding. And so you're going to be much more likely to have hematology on board to do IVIG to try to attack the antibodies that are trying to attack, so you're counter-attacking there, and then steroids to calm down that immune system process. This can, if it converts from IgM, right? IgM means it's right now that we have, and IgG for later. So if it converts into your IgG, then you start worrying, hey, this is going to be a chronic ITP that we're going to continuously see. So those are the times when you have longer term treatments, but most of the time the way to think about this is a self-limiting process. But once your IgM says, oh, never mind, we don't want to attack the platelets, then we are done with that process. Reminder for hemophilia. I think you guys talk about hemophilia and heme. Yep. So X-linked. So if you see a pants question where they give you a girl, it's probably not hemophilia. Right? This is going to come from mom down to her sons. So probably not going to be that. So A is 8, 9 is B. But they look the exact same in kids. So typically when you're thinking about children, is this going to be something that presents right out the gate after birth? No, it doesn't. When do you think it starts presenting? Yeah, anytime that they become mobile. So whenever that is. So if you're laying there like a little baby cockroach, probably nothing is going to cause these deep bleeding and deep bruises. Suddenly now you start crawling, you start pulling to stand, you start tumbling, and you start seeing these symptoms of this. So typically The symptomatic presentation will happen sometime in the first year of life, typically again once you are mobile. And it's minor trauma. So it might be the 1-year-old that is learning to walk and takes the spill that every 1-year-old does, and suddenly now they have a deep joint bleed. So that is how minor of a trauma to these kids that we are talking about. However much clotting factor they have is going to determine how much they clot. That makes sense. So that is your rate limiting step of, do you make any? Do you make some? Is it functional? And that will be what hematology is figuring out. So your PT again, because that was not those correct numbers, 3 and 7. So that one doesn't matter, but your PTT, who is looking at both 8 and 9, is going to be increased and elevated. Hematology is going to do this. So again, this is not something at the primary care PA level. This would be, oh my goodness, this is not normal that a child is bleeding into a joint as a 1-year-old. I need to make sure that they have a CBC at least that is done, and that they are off to pediatric hematology. To be aware and to refer. So we're going to avoid as much trauma as we can, which trying to tell a 1-year-old that is a lot. We're replacing the factor that's missing, so either 8 or 9. So just give them the recombinant factor. And then if you have or if you have hemophilia A, so it's factor 8 is involved, you can give desmopressin or DDAVP. So the way that that happens is it's functionally, so if you look at factor 8, it is helped by von Willebrand's factor to get to where it needs to glow in the clotting cascade. When you give DDAVP, it's functionally like a tray that helps carry it there. So that just helps with the factor that you do have to keep it from being pulled out of circulation and attacked. Von Willebrand's. So the reason that they want you to know both of these is because this is not X-linked. So you will still have bleeding with this, but all of a sudden now you have a little girl who's bleeding. And you have a history that's usually a little bit later in the course of her lifetime. So this one is actually more common than you see with hemophilia. And it's when you don't have that von Willebrand factor that helps factor 8 get over to its place in that clotting cascade and create that bridge then between for your initial clot. So you can have several different types of von Willebrand's factor. You can say your body says, I don't make enough. So, okay, that's type 1. I make enough, but it is defective. It is type 2. And then type 3, I do not make any. Super rare to not make any of this factor. This then will present in little boys and little girls. Every test question I have ever seen in my entire life, it is a female. And it is going to give you a female with a female family history. And so they're trying to tell you this is not X-linked. Don't pick hemophilia. That's what they're trying to tell you with that. And it will give you something about, hey, she had bloody noses as a child. She's always had very, very heavy periods. Her aunt, her mom's had very heavy periods. Things like that, to try to say, hey, there's a family history of this, and it is on an autosomal dominant pattern. So that is what you are looking for in that question. When you're looking at how do we see which one of the types is going on with this von Willebrand factor, ristocetin is one of the ways that we will test that. It's an old antibiotic that's not used for antibiotics anymore, but it can help to see if the von Willebrand factor is actually functioning correctly or not at all, or if it's even there. So if you have type 1 or type 2, so I don't make enough, or I make it but it is defective, I can give DDAVP then to help force function to either overcome not having enough and force more to be made, or force some to be made that is correctly made. So the only type that von Willebrand factor won't work for is type 3, where you make none. So telling it to make more if you make none is not super helpful. And then this is for y'all, just make sure when you're going through that you can be able to tell between von Willebrand's, hemophilia A, hemophilia B, and those slight differences. That is a question that has been on every board exam till the end of time. So you will have a question about that in your future. I think that is the end of heme. the end, so there's some reviews, so if you understand which one is going to be increased, decreased for all of your different lab values, and you have a pretty good grasp of that, those last couple of tables, you're well on your way for the level that you'll need to know, and then the specifics